Hi, everyone, and welcome. I'm Nick Hartog from Michigan State University, and I'd like to welcome everyone to our webinar tonight. So we've got the first case, and we've got one of my residents from DeVos Children's Hospital, Dr. Leanne Mansfield, presenting. And then we've also got Dr. Aksentijevich from the National Institute of Health here as our senior mentor. All right, Leanne, you can go ahead.
All right, thank you so much, Dr. Hartog. Good evening, everyone. Thank you so much for joining. I'm going to be starting with a case of recurrent fevers and hypogammaglobulinemia. So our patient initially presented to our institution at 20 months of age, a little boy. He came into the emergency department with bilateral knee swelling, more significant on the right than the left. He did not have a history of any trauma or any current fever. He was well appearing but fussy. He had a previous episode of bilateral knee swelling a few months prior that resolved spontaneously after a few hours. An x-ray was obtained of his right knee, which was normal, and he was sent home from the emergency department with pain control. He did return to the emergency department the next day with significant increase in swelling and pain. He was refusing to bear weight at that time. He was febrile to 39 degrees Celsius, and on exam, his right knee did present with effusion, and he was holding that joint in a flexed position of approximately 20 degrees. Due to our concerns, the orthopedic team was consulted, and a joint aspiration was performed on that right knee. The results of that are shown here. It had a pink cloudy fluid. Red blood cells were almost 38,000. White blood cells were 26,800 with 50% neutrophils. Here is some of his imaging. An MRI was obtained. The image on the left is a T2 that does demonstrate some abnormal hyperintensity with edema being present in the posterior medial periarticular soft tissues. It did involve the medial head of the gastrocnemius and neocollateral ligament complex. The image on the right demonstrates a T1 with some synovial enhancement and tiny effusion. Next set of images continues to show the peri-MCL enhancement on the left, as well as edema around the MCL on the right. Our radiologist's impression of this was suspicion for medial myositis and septic arthritis. Lab results were obtained at that second emergency department visit. It did show a microcytic anemia, white blood cell count of 12,100. RDW was 20%. Platelets were normal at 271. Absolute lymphocyte count of 5,000 and an ANC of 5,900. CRP did elevate between those two emergency department visits from 4 to 45, and ESR elevated from 25 to 61. He did have peripheral blood cultures obtained at that second ED visit, as well as the joint aspirate fluid, which finalized with no growth. Immunoglobulins were obtained. IgG was 475, though family did note he did receive monthly IVIG infusions. IgA and M were 12 and 20, and IgE was not detectable. Ferritin was elevated at 471, absolute retic count at 31,000, total iron 19, and iron binding capacity 233. Iron saturation was 8%. He did have a history of living in a wooded area, and Lyme IgG antibody was negative. Some additional history: he was born full term, induced vaginal delivery due to preeclampsia. He did require a 1-week admission to the hospital for hyperbilirubinemia requiring phototherapy. His past medical history, he had been diagnosed in an outside facility with hypogammaglobulinemia and iron deficiency anemia, and for those diagnoses received IVIG monthly as well as ferrous sulfate daily. His family history was not significant for consanguinity or immunodeficiencies. His maternal great-grandmother was noted to have scleroderma, and there was type 2 diabetes on the paternal grandparent side. His immunizations were up to date, and he is the only child of his parents, has some pet dogs, and again lived in a wooded area. So his hospital course, he was admitted to the pediatric hospitalist team. In addition to orthopedics, the infectious disease team, rheumatology, and immunology were consulted. He was started on cefazolin and was ultimately changed to clindamycin due to continued fevers. Throughout his hospitalization, his range of motion, pain, and edema did improve. His infectious workup was negative, and he was discharged home on Keflex. He did have a repeat admission 6 weeks later due to concern for 5 days of fever, abdominal pain, fatigue, and emesis. He had a Tmax of 40.1 degrees Celsius during that time, and his infectious workup was ultimately consistent with roseola. A little bit of information about his course prior to his hospitalization. His fevers and infections started after 6 months of age, often greater than 40 degrees Celsius. He was diagnosed with pneumonia 3 times and completed 12 courses of antibiotics the previous year. He did have an episode of acute otitis media, no history of sinus infections, and did have one event of cellulitis after receiving a vaccination. His course of IVIG was started approximately 1 year before we met him, and that was for possible transient hypogammaglobulinemia of infancy. At that time, genetic testing was not pursued. Lab work that was obtained prior to our meeting this young man was at 15 months. He had an IgG of 66, IgA of less than 6, IgM of 17, and undetectable IgE. He did have appropriate immune response to vaccinations. His flow cytometry demonstrated normal B, T, and NK cells. His CBC persistently showed microcytic anemia, normal platelets, and white blood cell was 8.8. Anemia studies were performed. Iron was normal, as well as total iron binding capacity. His percent transferrin saturation was normal at 20%. Ferritin was noted to be 288 at that time, with a reticulocyte elevated at 1.48%, and lead level was considered normal. Regarding his anemia, at the outside facility, he was originally diagnosed with iron deficiency anemia. He had received IV iron for that, as well as daily ferrous sulfate. There were no concerns with his childhood diet. Despite these efforts, he did not have a resolution in his microcytic anemia. The diagnosis of iron deficiency anemia was questioned, and he was referred to our colleagues at hematology. An oral iron challenge showed an appropriate response of absorption of iron. A hemoglobin fractionation did not demonstrate any abnormalities, and so a bone marrow biopsy with iron staining was pursued.
And then, Leanne, I was going to say, let's just pause there for a minute, let people look at the bone marrow while, and see if anybody has any thoughts at this point of things going through their head with the labs we've seen or anything like that. For any of the attendees, if you have any thoughts or questions, just type them in. Hey, Leanne, they're asking what stain this is. I believe you have that. Do you have that written down?
Let me see if I do. I wrote down iron staining.
It is.
Don't have
yeah, Dr. Yu,
else.
it's an iron stain is what we're looking at here. I believe, I don't know if it's more specific. What do you, anybody have any thoughts with the presentation or things that they would consider at this time? All right, Leanne, let's see. You can go ahead and talk about what you wanted on this slide.
I'm so sorry, Dr. Hartog, what was that?
Oh, I was going to say you can. I didn't know if you had anything to say on that slide, but yeah, we were talking about the differential diagnosis, which I'm not seeing anybody type in anything right now. So let's give 1 second to see if anybody's going there.
Sounds good. I'll give one more moment then. Because my next slide will give it away.
That gives the diagnosis. Yep.
All right. Are we ready?
I think so. I am not seeing anything else. So yes, you can go ahead and go on.
All right. Very good. Well, we did refer to our colleagues in the genetics department, and he did have a fever syndrome panel, which was positive for one pathogenic variant and one variant of uncertain significance in the TRNT1 gene. So ultimately, he was diagnosed as a compound heterozygous for TRNT1 deficiency, which is consistent with an autosomal recessive inheritance of sideroblastic anemia, immunodeficiency, fevers, and developmental delay, or SIFD. So his bone marrow aspirate smear is a little bit tricky to see, but it does have rare ring sideroblasts, as well as moderately increased storages of iron. And just as a reminder for those who aren't as familiar, the definition for the ring sideroblasts is at least 5 granules in the perinuclear distribution, going at least a third of the circumference of the nucleus. And we have our handy arrow sign for those. So the remainder of the course for our patient up until now, he is currently 3 years old. He continues to be seen regularly by Dr. Hartog and gets IVIG monthly. In terms of development, he has been seen by our neurodevelopmental team and does have expressive language delay and receives speech therapy for that. Had a normal neurologic exam. In terms of cardiology, he had a normal echo. He's been seen by audiology and had a normal hearing screen. Ophthalmology and a retinal specialist have since diagnosed him with retinitis pigmentosa, which is commonly seen with this deficiency. Most recently, he's been having some recurrent knee and ankle arthralgias, abdominal pain, and fevers. A cytokine panel and IL-18 were obtained and were normal, and we're currently considering starting a TNF inhibitor in light of recent literature. So just a little bit more about TRNT1 deficiency. It's incredibly rare. I believe Dr. Hartog and I have heard of, approximately 30 cases. It's autosomal recessive. TRNT1 gene encodes for a tRNA processing enzyme, CCA adding transfer RNA nucleotidyl which is important to correctly attach amino acids for protein synthesis. So variants in TRNT1 do lead to a complex autoinflammatory disease with variable severity as well as a very high morbidity and mortality. Unfortunately, it is often fatal in these little ones, and the spectrum of disease is quite large. Prior to genetic testing, it was thought that SIFD and retinitis pigmentosa with erythrocytic microcytosis, which more commonly presented as an adult, were separate things, but now we understand them to be a continuum, a spectrum of this TRNT1 deficiency. In the literature, other things that I saw it presenting with were IUGR, failure to thrive, diarrhea and vomiting, arthralgias, arthritis, hypotonia. Other neurologic signs and symptoms were cerebral atrophy, cerebellar atrophy, seizures, sensory neural hearing loss, cellulitis, brittle hair or woolly hair I've seen described, mucocutaneous ulcers, dilated cardiomyopathy, which unfortunately sometimes leads to death in these children, as well as multi-organ failure and nephrocalcinosis. Regarding treatment, We don't have a lot of research about this yet, but the majority of patients do require IVIG infusions as well as blood transfusions. The blood transfusions do put them at increased risk for severe iron overload and sometimes require iron chelation. So the ferritin can kind of be a tricky one in that it's an acute phase reactant, but also can be the sign of that iron overload, is my understanding. Some patients have had a bone marrow transplant with some success. In more recent literature, had 4 out of 4 patients that were treated with TNF inhibitors have suppressed inflammation, normalized inflammatory markers, decreased red blood cell transfusions, and improved growth. So it's just really important for us to recognize this early so that we can hopefully start some treatment for these little ones. So in summary, TRNT1 gene encodes a tRNA processing enzyme, and variants in this can lead to a complex multi-organ autoinflammatory disease with a wide variety of clinical and immunologic presentations, including the B-cell immunodeficiency, hypogammaglobulinemia, recurrent fevers, sideroblastic anemia, developmental delay, and retinitis pigmentosa. The case we presented today included several of those. And TNF inhibitors have recently been shown in the literature to be a promising treatment option in a small cohort. I'll now open it up for questions and discussion.
All right, we have a few different questions here. One of them is from Dr. Yu, and were sideroblasts seen on the peripheral smear? And so, no, they were not. They're only seen on the bone marrow analysis. We had to look, and we reviewed it with the multidisciplinary team pretty closely before we saw and identified them, and so they were not very clear to be seen. But then they're even more clear once we had the genetic diagnosis too. And then there's one question about what the differentials were from the rheumatology team, and we've actually got our rheumatologist on here. I don't know if Dr. Kessler, you see that, and remember what your original differential was, but I know in the original admission, one of the thoughts was this is infectious arthritis, but then he started presenting with more and the abdominal pain and the recurrent fevers, and as we got to know him over the course of about 2 months or so, it became clear that he had something going on a little bit more, and that he, with all of these fevers, they were consistently non-infectious and consistently had inflammatory manifestations with them, which is, for us, what really triggered us to do more, and also the hematology team really not having a clear explanation for the anemia that was quite microcytic, and all that kind of put together is what brought that to this is our thoughts that this is more of a recurrent fever syndrome. Somebody asked, is this on periodic fever panels? It is on the Invitae one, which is what we in particular sent. I'm not sure about the other ones. And then I kind of turned some of these questions over to Dr. Aksentijevich. We've got some people asking about other anti-inflammatories like IL-1, IL-6, colchicine, and then I know one of your papers that you published recently is more on the TNF inhibitors for treatment. I was wondering if you could talk about that.
Yes, that's correct. So we have also kind of limited experience with the treatment of these patients because we didn't have that many patients, to begin with. And I've heard from colleagues from other parts of the world that treatment with IL-1 was not very efficacious in suppressing at least inflammatory phenotype in these patients. And our study showed that the treatment with anti-TNF was more successful in suppressing disease activity, again, inflammatory disease activity. And once we suppressed this inflammatory disease activity, that also helped a little bit with the anemia, at least in some of these patients. So I would say at this point that anti-TNF treatment is the best option for patients that present with inflammatory phenotype. However, I would also say that there is a lot of phenotypic variability in this disease. There are patients that can present with severe B-cell immunodeficiency primarily and without much inflammatory symptoms, or they can present with inflammatory symptoms and without immunodeficiency. So we see really a great variability of disease presentations in different patients that cannot be just explained by the genetic findings in this particular gene. All these variants are hypomorphic, they are hypomorphic to different extent, but there must be a role for other modifying gene alleles because we see a lot of phenotypic variability among affected siblings, for example. So there is a role for other genetic modifiers. So I think that a bone marrow transplantation could help with this disease, providing that these patients are diagnosed early in their life and before they basically develop complications of this disease. So that's what I would say.
And then for another question, when you're talking about the TNF inhibitors, is there one that is working better than others?
Well, we, as I said, we have a limited experience, but we see patients with other autoinflammatory diseases that include also intestinal inflammation. Typically, we start with etanercept, because it's easy to dose, but some patients they require treatment with stronger TNF inhibitors, such as infliximab, etc. And it is helpful definitely with resolving the GI inflammation in at least a couple of patients that we treated with TNF inhibitors. So, yeah, but typically we start with etanercept.
Thank you. And any other questions from people out there?
I would also make one comment. In a patient like this, where you have really early onset symptoms of systemic inflammation, immunodeficiency, and in this case, anemia, sideroblastic anemia, but even if there is no sideroblastic anemia, just microcytic anemia or anemia of chronic disease, I think that you should really think about doing genetic testing even earlier. I mean, this patient got to be tested at age of 2, not that that would change much his course of disease, but nevertheless, I mean, you have patients that start early in their life with this constellation of symptoms that include, different, types of immune dysregulation. I think it's advisable to do genetic testing, and there are many targeted gene panel available in different diagnostic companies, and they are not that expensive. I'm not advertising for the Invitae company, but I've heard and we tested some of our patients. It's not that expensive. They're targeted gene panels, so I think that this is all doable.
All right, then we've got another question out there asking with his normal inflammatory markers and the normal cytokine panel, but he's still having, especially more recently over the last 6 months, more abdominal pain, joint pain. Do you think in that case that would be enough of an indication to start the TNF inhibitor? And I can tell you that question's coming from our rheumatologist.
Yes, I think so, because when we did cytokine profiling in serum samples and simulated PBMCs, we didn't really find always evidence for increased production of pro-inflammatory cytokines. However, we found evidence for inflammation at the tissue level. So basically, we did immunostaining of GI biopsies from a patient with severe IBD, and there we saw evidence both for high expression of IL-1 and TNF cytokines. So, the lack of cytokine production in peripheral blood or serum samples, it doesn't mean that there is no evidence for tissue inflammation in patients with TRNT. And I think that they need to be treated with anti-TNF therapies.
And then we've got 2 other questions kind of resolving around the immune deficiency part. And one is besides the hypogam, is there any other immune phenotypes observed? And then Dr. Yu's got a question that he had low IgG, quite low IgG, but his specific antibody titers were normal. Is there a reason for that? Do you see that, the hypogam, without any necessarily deficit in the response to vaccination?
At least in our patients, we had also evidence. Again, we have limited experience, but we have evidence also for antibody titers. So I don't really have any explanation why this particular patient would have hypogam and normal titers. So. Synovial, yeah.
Oh, I was just going to say, another question is, have you looked at the synovial tissue at all? Because I don't know that I've seen any studies that have been published about that. and what kind of infiltration there is in the synovial tissue?
I honestly cannot recall, but I would expect to see some neutrophils and, myeloid cells infiltration. And of course, always in patients that have systemic inflammation, even if they have what we consider typical autoinflammatory diseases, which means that they're mediated predominantly by myeloid cells, there are always some, cells of the adaptive immune system in affected tissue. But based on what I know, what is seen in skin biopsy of these patients, basically neutrophilic infiltrates, evidence for panniculitis, etc. I would think that you would see similar kind of cell infiltration also in synovial tissue, although I can't really recall the data from that.
All right. I think we'll thank you, Dr. Aksentijevich, and we'll wrap it up there so we don't run into too much of the of Yasmin's time, and we can turn it on over to them.
Hi, everybody. My name is Yasmin. I'm one of the allergy immunology faculty at Vanderbilt. I am going to present a case tonight that I think nicely illustrates sort of some dilemmas in thinking about clinical management of patients when you have early genetic diagnosis, and hopefully stimulate a discussion about best management for this specific genetic diagnosis. I first want to say a huge thank you to my mentor, Dr. Forbes Satter, who has been so helpful to me with this case, and I think you guys will be happy to hear from her because she's truly an expert in the field. So let me first tell you the story of the patient. He was at that time a previously healthy 9-month-old male who presented to our emergency department with fever for 13 days. He had been initially diagnosed with acute otitis media, was treated with Septanir, but fever persisted, so their PCP recommended that they come on into the emergency department for further workup. The ED got a CBC with differential that showed pancytopenia. As you guys can see, his white count was down with an ANC of 870, ALC of 1760. Hemoglobin and platelet counts were both low as well. He had a CMP which showed some transaminitis, specifically with an AST of 875, an ALT of 360, and a normal bilirubin. On exam, they felt like his abdomen was distended, and so they got an abdominal ultrasound, which showed some hepatosplenomegaly. And at that point, he was admitted to our HEMONC service for further evaluation. Infectious disease was consulted and did a broad infectious workup, as you guys see. He had negative PCRs for CMV and EBV. Blood cultures were no growth, both bacterial and fungal and AFB. He had negative parvoserologies and negative PCRs for HSV, adeno, HIV, and HHV6. Our HEMONC team was thinking along the lines of malignancy versus HLH, and so they did a pretty extensive workup that was significant for an elevated ferritin, very slightly elevated IL-18, low fibrinogen, low NK function, elevated soluble IL-2 receptor, elevated soluble CD163. The patient had normal mean cellular fluorescence for perforin and granzyme in NK cells. It was slightly increased for perforin in CD8 cells. Normal CD107A mobilization and normal SAP and XIAP expression by flow cytometry. They then got a bone marrow biopsy that showed, as you guys remember, he had decreased white blood cells, red blood cells, and platelets. It showed that he had a normal cellular marrow with trilineage hematopoiesis, but it did show that he had some macrophage hyperplasia with hemophagocytosis, normal cytogenetics, and normal flow cytometry. So at that point, the diagnosis was HLH. And as you guys can see, he fulfilled 7 of the criteria with fever, splenomegaly, cytopenias, hemophagocytosis, low NK activity, elevated ferritin, and elevated soluble IL-2 receptor. And at that point, dexamethasone was started, steroids were started for treatment of HLH. And over the next day, he defervesced and seemed to be feeling and doing a lot better. They got some additional workup with a brain MRI that was unremarkable. They did comment that he had some heterogeneous areas of FLAIR hyperintensity within the white matter. They felt like that was due to incomplete myelination, which was related to the patient's age, and he had an LP, which was normal and did not grow anything from bacterial or fungal cultures. So at this point, he's doing a lot better. Everyone is feeling better about him. We're about 3 days into admission, and his histoplasma, urine and serum antigens result. For us, we have to send them out, and they take a few days to come back. So it was positive both in urine and serum, and it was reported out as above the upper limit of detection, which for the MiraVista lab is 19 nanograms per ml. So we ask our pathologists to please take another look at the bone marrow, and they, by using right stain, found that it was positive for histoplasma. So at that point, the diagnosis sort of shifted to disseminated histoplasmosis causing secondary HLH. And so ambisome was added to dexamethasone. Does anyone have any questions? Are we feeling good about the case so far? Yes? Okay, then I'll continue. Where does he live? We live in Tennessee. They are a very active family. They like to hike and camp and fish, so they're outside a lot. And he is 9 months old. So at that point, our question was, well, is it normal for your average 9-month-old to have disseminated histo? And so we started an immune workup. And at that point found that his cytopenias were worse. As you guys remember from admission, his ALC was above 1,000, and here it was 490. Specifically, his T and NK cells were really low, with a CD4 count of 100 and a CD8 count of 82. He had a pretty normal RA-RO distribution. CD4 to CD8 ratio was 1.2. And at that point, his immunoglobulins were within range for his age. He had received 3 sets of vaccines, so 3 DTaPs and 3 Prevnars. He had protection to the tetanus component, no detectable protection to diphtheria, and not great protection to strep pneumo. At this point, our first genetic test resulted. They had sent off the familial HLH panel to Invitae at the early in the admission, maybe day 1 or 2, as they were thinking about HLH. And there were no pathogenic sequence variants. And you guys can see the genes that are sequenced on that assay. Throughout his hospital course, he improved day over day. Ultimately, dexamethasone was tapered off, his ferritin normalized, as did his soluble IL-2 receptor. We have one question. Do we have cytogenetics results on the bone marrow? We do. They commented that he had a normal karyotype and no other abnormalities were found. The patient completed about 4 weeks of ambisome, was transitioned to itraconazole as outpatient therapy. His histoplasma antigen continued to have low-level positivity in blood. They reported it as less than 0.4 nanograms per deciliter. However, that is above their limit of detection, so they reported it out as still low-level positivity. We saw him for follow-up in our combined immunology infectious disease clinic and got some repeat immune labs. And he had worsening hypogammaglobulinemia. You can see that his IgG is less than it was a month ago. And lymphopenia was improving, but still not normal. At this point, this is a month after discharge, his total C3 count was 1,000, CD4 669, and CD8 274. He had completed his vaccines at that point and had much better protection to Prevnar with 12 out of 12 serotypes positive, normal NK numbers, and normal CD19 numbers. He had normal proliferation to mitogens, but decreased proliferation to tetanus antigen. We have, for whatever reason, have a lot of trouble getting mitogen and antigen proliferation done correctly by our lab. And so we've sent repeat antigens a couple of times and they have been canceled. So I don't have a Candida result for you or a repeat tetanus result. We have a question about IgE. His IgE was normal. And I don't remember what his eosinophil count was, but it was not elevated. So at that point, we sort of continued our detective work and decided to send more genetic testing. MVT was very kind to run their PID panel for us, which covers 207 genes, and it came back with a heterozygous mutation in STAT1. This mutation is in the coiled domain, which is near residues that are really important for dephosphorylation of the STAT1 molecule. And so the mutation leads to gain-of-function transcriptional activity. It's been previously reported in several patients. We were a little bit surprised by the result at first, but as we read a little bit more about it, it seemed to make more sense. As you guys know, the clinical phenotype is really heterogeneous with this disorder and with other gain-of-function variants. And HLH has been described as inflammatory sequelae of the pathologic inflammation in this disease. And so his diagnosis, autosomal dominant STAT1 gain-of-function disease. Thus far, we have a question, did he have any autoimmunity? And we have not found evidence of autoimmunity in him yet. He did not have history of thrush. No thrush, no nail infections, really no problems with CMC. At this point, he is 27 months old. He is still on itraconazole at treatment dosing. And we have put him on acyclovir and azithromycin prophylaxis. Carl Yu is pointing out that he's already on itraconazole, which is very true, but he did not have problems with thrush prior to his presentation with histo and subsequent treatment with itraconazole. So the things I really wanted to discuss tonight with this group of immunologists, what do we do with this baby? Is there precedence for starting ruxolitinib in a 27-month-old toddler who doesn't have active inflammatory disease, but history of, disease in HLH? The variant that has been described in this patient, the case reports and the descriptions that are out there don't have, the patients didn't really have the autoimmune side of this disorder. Some had hypothyroidism, some had pulmonary infections. One patient had disseminated coccidioidomycosis and died at age 17. And then one patient had CMC as an infant, but they really didn't have a lot of issues with autoimmunity. We're also curious, are there other things that we need to be thinking about immunologically for him? Is anyone out there doing other functional studies that might help us predict the severity of his phenotype? And at what point do we think about transplant for him? Should we be thinking about it in, patients that are at a relatively healthy point before badness starts, or is the risk with transplant in this set of patients too high? So these are the kind of questions that I would love this group to kind of think about and help us think about, and hopefully Dr. Forbes Satter will help us think about them as well.
Can you hear me?
Yes.
Yay!
We have another question. Did we start PJP prophylaxis? We have not started PJP prophylaxis specifically yet. could we consider ruxolitinib bridge to transplant given poor outcomes in patients with more advanced disease? I think that's an excellent thought. Were there no other variants? There were no other variants. My N equals 1 histoplasma HLH patient who needed a transplant did not make it. The histoplasma was very much under control / undetectable, but it just came back. And I think that's what we're worried about also.
I think that this brings up a lot of important questions. So, the transplant data is not that great. What we know so far is that it is about 40% survival. And these patients are also very exquisitely sensitive to other fungal diseases aside from CMC. And autoimmunity is a very big risk in this population. And as patients grow, they tend to accumulate more complications. We have some patients who had a clinical phenotype of, I'm not sure what the echo is. Thanks, Manish, for pointing out. Maybe I'll mute but anyway, before I finish, is that a lot of these patients do progress when they have one complication to accumulate more. So one of the things we think about is starting ruxolitinib early. I'm sorry. Helen. One of the things that we have done is start Ruxo early and monitor the patients. If they do well on ruxolitinib, although we don't know the long-term complications of ruxolitinib, that's really helpful. Kelli asked about baricitinib, which is a really good thought. So the difference between baricitinib and ruxolitinib is that ruxolitinib is more of a JAK1, JAK2 inhibitor, but baricitinib is a little bit more specific to JAK1. And one of the reasons why JAK1 might be a little favorable is in the side effect profile, because JAK2 is important for a lot of hematopoietic growth factors. And what we are concerned about is the long-term sequelae of suppressing a lot of these important hematopoietic growth factors, even in a gain-of-function disease. We don't have enough data on these patients to understand what happens to them on long-term ruxolitinib. So baricitinib would be a very nice option for this patient. And I agree with Ivona that if this patient were to flare again with the HLH, the interferon monoclonal antibody would be a very nice option. In STAT3 gain of function, we have had present with HLH that did extraordinarily well on a JAK inhibitor before transplant. And so I think targeting the disease specific mechanism, it might be a lot nicer option. And the other thing is that the interferon gamma monoclonal antibody is quite expensive. So although indicated for HLH, it's quite a pretty penny to use. So Ruxo is challenging in children because it only comes in pill form, but we've been able to figure out how to dilute it in sterile water. And so we have been able to use it in patients with NG tubes, G tubes, or that don't take pills by mouth. So that's how we've gotten around that. Any other questions? So one of the things that we're really interested in is looking at the genotype-phenotype correlation. We, at least in NK cells, have seen a significant stark difference in the phenotype for DNA binding domain mutations as opposed to the coil-to-coil domain, or even in the transactivation domain and NSH domain. So I think that a lot of patients in the future, hopefully, will be able to understand why some patients present more with an infectious phenotype versus an autoimmune phenotype. The other thing that is very curious is in the reports of this particular mutation, infection phenotype was overwhelmingly more present than the autoimmune phenotype, and specific lung disease was also an issue in 2 patients. So.
Unmuted.
It looks like we have another question from Edith asking, I've had a patient on Ruxo that initially did well, but then had infections and poor response when restarted. Second patient didn't respond to Ruxo at all. Should they have considered transplant earlier? At this point, neither has had transplant, but both have advanced autoimmune issues.
It's really hard to say. I think that one of the things that, so Edith, I know about one of the patients that you are talking about, and it's really hard to determine, because we do know that initially ruxolitinib does well, and in some patients where it stopped and then restarted, for some reason there's not as much as an effect once the medication's restarted. A lot of the patients that we take care of are on the younger spectrum, so I'm not sure if we've caught them early enough and started them on ruxolitinib early in their disease course, because I do believe there's a point at no return where the JAK inhibitors don't work. And I also think that in some cases with the autoimmune disease, some of the patients need a higher dose of ruxolitinib, which of course puts them at risk for infection. So I think it's a really hard thing to say. We have sent patients to transplant who were very well under control, who had significant inflammatory complications during transplant and didn't do well. And then, of course, in Jen Lighting's paper in JACI, where she looked at the international cohort, those patients that had a higher percentage of secondary graft failure, and no one's really quite the theory is behind that is it might be interferon gamma leading to that issue. But I think that the problem is no one really knows exactly why these patients have more secondary graft failure other than just being generally inflamed. Yes, Manish, you said any head MRA. Any chance arterial lesions improve on JAK inhibitors? Not that we know of as of yet. And this is exactly where a transplant wouldn't help and might actually put the patient at more risk. So that brings up a good point. When I make the diagnosis of STAT1 gain of function, I get a head MRI on my patients at baseline. And that is generally a little bit of a fight sometimes with insurance companies, but because it's actually published, a well-published complication, it can be helpful. An MRA, because you want to look at the vasculature, Kelly. And Edith brings up a good point about herpes viral disease on JAK inhibitors. So Edith, was your patient on acyclovir prophylaxis before developing the varicella infection? One of the things that we do is start all of our patients with STAT1 gain of function who we started JAK inhibitor with acyclovir prophylaxis or Valsite. So we keep them on, oh, that's too bad, Edith. We keep them on acyclovir or some kind of antiviral, anti-herpes prophylaxis that while they're on JAK inhibitors. So that's one thing that we do in concert with starting the JAK inhibition. So I think my echo comes when either Yasmin or CIS. What do you think? Did that work?
Yes.
Yes. So this is a really, really tough situation. Transplant is not well sorted out in this disease in terms of what kind of regimen is best, what kind of prophylaxis, whether or not JAK inhibition before transplant. It definitely helps calm the disease, but then the question is, how does that get integrated into the transplant regimen in terms of GVH prophylaxis or treatment of engraftment syndrome, for example? The other thing that we worry about is that although you might put these patients through myeloablative or submyeloablative conditioning, we worry about the tissue resident cells that weren't suppressed with the conditioning regimen and whether or not those particular cells are the ones that overtake in an inflammatory situation during the early transplant time. So that's one of the issues that we've toyed with as where do we put a JAK inhibitor in the transplant conditioning or prophylaxis process, and is there a role for it earlier on in prophylaxis? And that's that's where a lot of the conversation around whether or not what kind of JAK inhibition is best in these patients, and is that important to consider in the transplant period. Scott asked if there's any role for peripheral interferon score entailing JAK inhib therapy in STAT1 gain of function. I think that there probably is. One of the other things that is clinically available is CXCL9, which we've been using, although both interferon, type 1 and type 2 interferon are activate STAT1. We have very poor mechanism clinically or test clinically to follow these patients and to see whether or not we are appropriately dosing our JAK inhib therapy. And so what we've looked at is very proliferal markers. So we send perforin because we found in the more severe cases in the DNA binding domain mutations, perforin is suppressed and is restored with JAK inhib therapy. And then we've also looked at CXCL9. IP10 and CXCL10 are not available clinically. So agreed, Scott, but one of the things that we have to consider, and I think is helpful for the immunology community in general, is how can we robustly follow these patients on a widespread basis. And so it actually makes the rest of us who have involvement in clinical labs and research and development more motivated to try to get some of these on our clinical panels. It looks like we've come up on the 8 o'clock hour. I'm going to mute myself so you got, Yasmin, you can wrap it up.
Unmuted.
Thank you so much. That was really, really helpful. Thank you, everybody, for asking so many questions and giving so many thoughts. I think that Kelli is going to close us out with some hot new literature. Kelli, are you ready?
Yes. Yes, perfect. I only have 2 slides, and we will make it really quick since we're already at 9 o'clock Eastern Standard Time. This is just a short segment that was a thought that we would add to our monthly webinars, just so we could all remain current in all of the amazing articles that come out each year for clinical immunology. As we know, at the annual meeting, there's a section where they highlight some of these articles, but we just felt like maybe it would be a great opportunity for us as early career immunologists on the committee to read more, but also to share something we thought was interesting that we read with everybody who's participating. So I picked an article, and then in the future, every month, one of the moderators from the 2 cases will also present an article. So it's supposed to be 3 to 5 minutes. And so I picked an article from Jockey, and it was this great paper by PIDTC committee, but Dr. Marsh, and it was basically looking at CGD colitis, the CGD IBD cohort, and whether or not it adversely impacts stem cell transplant. So if I can just flip to the next slide. Here we go. Okay. Oh, shoot. Okay. Main objective of this article was just to investigate the effect of transplant on CGD colitis. The methods were looking at a retrospective chart review for 145 CGD patients, a third of which had IBD diagnosed clinically. So 2/3 didn't have IBD, and all of them received allogeneic stem cell transplant, and this was among the 26 PIDTC centers over a 11-year span. And just looking at the key results, the main things were both populations engrafted very well, 89% with IBD engrafted, 93% without IBD. There was not statistically significant difference. And there was no significant difference between upper GI acute GVHD and lower GI acute GVHD in these patients with and without colitis. The cumulative incidence of acute GVHD grades 2 to 4 was 30% versus 20% in those with IBD versus those without IBD. So definitely a trend, but not statistically significant. And I think some of those are pretty much on par with other transplant patients in general. And the cumulative incidence of chronic GVHD was 18% versus 27% in those without IBD, which was kind of interesting. Again, a trend, but not statistically significant. And the 2 big results that I think are important to look at are the 5-year survival was similar in these patients with IBD and without IBD, so 80% and 83%. So still excellent survival rates at 5 years. And whether they had colitis or active colitis really didn't affect their survival. And 100% of those surviving evaluated or patients with evaluable data who were post-transplant with colitis had resolution of symptoms by 2 years, half of which by 100 days post-transplant had resolution of symptoms, which I found that pretty clinically significant. And then based on those 2 findings, the big conclusions were some people had complete resolution of their IBD symptoms. And so the transplant was curative for their CGD colitis. And we certainly shouldn't be delaying transplant for these kids with active colitis, because colitis is not a contraindication for transplant and does not increase the risk for mortality. So I thought that was important because, sometimes we think of the CGD colitis patients are they're the sicker of the sick. And sometimes we get worried about taking those sick kids to transplant. But really, this paper kind of gives me a little breath of fresh air with thinking like, yes, we should just pursue our normal treatment for CGD. These kids are doing similar, if not better, with transplant. That's my summary. If you guys have future interest in presenting even just the article or sharing articles or just sending articles for suggestions, we're trying to give highlight articles that were presented or came out in the month-ish before our next webinar. Thank you guys for participating. Carl, no conclusions as to the age of transplant were mentioned in this. Thank you.